today's presentation is entitled Engaging Patient Partners in Your CIHR Grant Application, Everything You Ever Wanted to Know. And it's presented by Maureen Smith and Andrea Chow. So today's presentation will be about 45 minutes and will be followed by a 10-minute Q&A. We encourage you to use the chat feature and the Q&A box to submit your questions throughout the presentation, and we'll try to get to as many of them as we can. And please note that today's session is being recorded. So a little bit about the ACT Consortium, ACT Canada. So the ACT Consortium was funded by CIHR in 2022 to establish and was established to facilitate, optimize, and accelerate the conduct, implementation, and results translation from high-quality, high-impact randomized control trials to improve health in Canada and around the world. The ACT Consortium's governance model is composed of 23 committees and working groups, and today's webinar is brought to you by ACT's Training Committee. Because the ACT Coordination Centre is located at PHRI in Hamilton, Ontario, we did want to take a moment to acknowledge that we recognize and acknowledge that we are located on the traditional territories of the Mississauga and Haudenosaunee Nations and within the lands protected by the Dish with One Spoon Wampum Agreement. This agreement was created to bind the nations of the Haudenosaunee Confederacy to the Great Law of Peace. The dish represents the shared land, while One Spoon reinforces the idea of sharing in peace. We hope to bring a similar spirit of collaboration to the work being done by the Canada-wide members of the ACT Consortium. And with that, I will introduce today's speakers. So our first speaker is Maureen Smith, a proud, committed patient partner whose engagement stems from a rare disease diagnosis in childhood. She co-leads the patient engagement with the Inform Rare Research Network and is the patient engagement lead for the Impact Clinical Trials Training Platform. Maureen was recently appointed as the first patient member on Canada's Drug Agency Board of Directors. Our second speaker is Andrea Chow. Andrea coordinates the research project designing interventions to improve delivery of healthcare for children with inherited metabolic diseases, led by Dr. Beth Porter at the University of Ottawa. In this role, she works closely with the project's patient and family partners. Her interest is in the research that responds to the needs and priorities of communities affected by health inequities. She has previously worked with communities and organizations affected by HIV/AIDS. In her spare time, she teaches and practices yoga. So a warm welcome to our speakers, and thank you so much for taking the time to present today.
Hey, I think I'm on first. Just wait for the slides to go up. Thank you, Sita, for that beautiful welcome. Oh, and a little update. As of January, I'm also the co-lead of the ACT Patient Engagement Committee along with Stuart Nichols. So adding that to my my tasks. So all right. So thank you so much. Thank you for joining us. We'll find out in a few minutes. It's actually in the virtual room. But we're really thrilled to be here today to present this to you. We did a similar presentation last year that was aimed really for the patient partners, because patient partners often also support other patient partners in helping the research team with the grant application. So really happy to see everyone here. And of course, we've timed the webinar to coincide with the spring project grants, which I'm sure you're probably all busy at working at developing now. I think the letters of intent are due very soon. And on January 8th, the priority areas for the Project Team Spring grants was announced. And there is one on patient-oriented research priority within a specific pool for innovative clinical trials. I think Andrea's going to put that link in the chat for you. So that might be of interest to many of the people who are on this call. And so that's kind of the motivation for the timing and for this presentation, which we hope you'll find really useful. So next slide. So just to review that you're at the right place. We had three webinar learning objectives. This is what you expected. You may be in the wrong webinar. So we really want to briefly review the ways in which patients can contribute as partners on your CIHR grant application, identify the challenges and barriers to patients and partnering on those projects when it comes to your grant application, how you can support those patient partners, and then really take a deeper dive into the considerations that are specific to grant application requirements for researchers working with patient partners from groups who are frequently underserved by health research. And those are our objectives. So on to the next slide. As Ipsita said, you can put your questions directly into the chat. We might try to answer some of them as we go along, and then we'll have it certainly a dedicated question and answer period at the end, and try to get to as many as we can. And the presentation will be available on the ACT Consortium website shortly after. So if you're the slides and the audio recording. So just looking, in a few seconds, we'll put the polling in so we can see who's actually here. But just so that you're aware, and I'm sure you are aware, the Tri-Council is going to change grant application requirements. I did attend the webinar. I attended the French version of it to make sure that we weren't giving this webinar and that the process was going to be changed. And I was reassured that it's not changed for the current grant applications. We also believe that the barriers and challenges that we're going to identify may still apply in the new version. It's hard to get a definitive answer to how much patient engagement there was in the new requirements. So we'll anticipate that a lot of what we say will probably still hold for your work moving on as they start bringing in the new grant requirements. So I'm going to ask, I think it's Alyssa, who's going to launch a bit of a poll to find out who's in the room today. Thank you. And here we go. Oh, very interesting. This is great. So the majority, 57%, are research staff. Very important. Often the people who are at the frontline supporters of these grant applications. Great to see some patient and caregiver community partners too, and clinicians. Just everyone who's here we're really happy to see you, and hopefully you all take something out of this. Okay, that's great. And what about people? Yes, so we've got a range of experience of people who've submitted grant applications with patient partners. That's great. It's in the plans, I like that. Okay, so here we go. I'm here to learn, 35%. That's great. All right. And your level of comfort, that's great. So even those who are comfortable would like to learn more strategies. Oh, we got a couple of people who are pros. That's good. You can add some more help in the chat. Okay. I'm uncertain. I'm overwhelmed. Yes. Okay. Thank you. Thank you so much for answering those poll questions. That gives us a good idea of what of who's in the room. So welcome again, and I'll go on to the next slide. Okay. So just to make sure that we're all in this, speaking about the same thing, we're talking about patient engagement in clinical trials. So really actively collaborating as partners on your team, and that would be like the CIHR definition. And when we talk about patient engagement, that's everyone. So people with lived experience, their caregivers, their families. In some cases, it's the public, because you could be looking at, trials where you're not necessarily a patient yet. So it really is that broad definition that CIHR uses, and is not to be confused with the participants in clinical trials, who are also very important, but we are here, you don't put them on your grant application. So we're talking about the people who are going to be on your grant application, and there's 3 different roles that they can play on your application. They can be co-principal investigators, And yes, there are patient partners who are co-principal investigators. I've been one since 2016, so and still hanging in there. They can be co-investigators or they can be collaborators. So all the roles that all of your other research and clinician and funder friends are playing on the grant can also be taken up by patient partners. And there's different requirements for those categories, and sometimes they differ depending on the category of the grant application. And Andrea is going to really take a deep dive into the barriers and the challenge. But from a patient perspective, which is what I'm here to offer, it really is about the complexity of the process and the nature of the information and questions that are asked. And that's not because of you. That's the system, and that's the system that you have to work within. And years ago, they introduced the applicant profile CV, and that was meant to address some of those concerns of asking patient partners for a common CV. But as you'll see, there remains many challenges even within that applicant profile CV, and the most significant contributions in the types of information that they're asking patient partners to give. So I'll go on to the next slide. This is just my favorite slide. I like to put it in. I throw it in all my presentations, whether it fits or not. And so if you're wondering, why should you do patient engagement? I think this probably answers a lot of those questions. So there you go. Should help you. Okay, next slide. All right. So I'm just going to address a couple of the myths, that about patient engagement clinical trials, and that they're too complicated, and for patients to be meaningfully engaged as partners. And so it's simply not true that it's too difficult to explain clinical trials and research methodology. It takes work, and it takes you working with your patient partners to make sure that your wording is makes sense to them, but it's not something that should be a barrier for you. And that youth are vulnerable and could be harmed, which is true. We're all vulnerable, and we all can be harmed. But if you use a trauma-informed approach, and you can mitigate a lot of that. Some people believe that caregiver engagement includes youth perspectives. False. If you speak to a youth, they'll tell you very clearly that they have their own opinions and they want to speak for themselves. And finally, some people are concerned about the ethical implications when engaging with minors, which is also true. And there definitely have to be special considerations into place. So that's a couple of my favorite myths. There's many others, but those are the ones that I kind of like to highlight just to start off. Okay, I'm going on to my last two slides. So why would you want to engage your patients in research? So, it's the power of the experience of a condition or disease, which is the expertise that we bring. Making sure that your research questions are important to us. Your outcomes of your clinical trials and of your research are things that are also relevant and important to us, and including the quality of life measures. You're going to have the new currency of the real world input on risk tolerance and interventions, and the power of data. And there's a lot of focus on that now, and so you'll be able to have a work with your partners to get really valuable information on that. We're focused really on patient-centeredness, and we think about the ethics and the safety and the urgency of the trial, which is often really important. And of course, patient partners have connections to other patients like them. That really helps with your recruitment and your dissemination of your research findings. So that, I could have a list of 50 items, but I picked a couple of the ones that I thought were most important. And I'll just put this out here. This was a resource that was developed by Nancy Butcher and a couple of people who she teamed on when taking the family engagement in research course, and they produced this really helpful resource where the trial is separated into the four areas with a couple of prompts for you to think. Okay, this is where patient engagement could really benefit. There's more than that, but this is a good way for you to start and to think about how you can integrate those patient voices in all of the whole life cycle of your clinical trial. So I'm going to stop there, And I'm going to turn it over to Andrea, who's going to really bring it to you from a researcher perspective and from a person who's been supporting people on grants. Okay.
Thanks so much, Maureen. And before I start, I just want to say that Maureen is an incredible both patient advocate, but also somebody to partner with. And Ipsita mentioned it in her introduction of Maureen, but it's really quite a landmark that Maureen has been recently named to the Canada Drug Agency's as a patient partner to them, because that's really somewhere where there's not traditionally been a lot of patient input, and I have no doubt that Maureen is just going to really bring a wealth of experience and advocacy on behalf of patients. I've been lucky enough to work with her on a number of years now, and so in the work that we've done together, we've done a lot of work that has engaged patient partners, including in the CIHR grants application. And that was just such an eye-opening experience, such a learning experience for us. And we really wanted to share what we've learned over our years with you. So when we're thinking about engaging patient partners on our projects, on our research projects, we really want to be doing this as early as possible, getting them involved. I mean, for all of you, I think if you've been working with patient partners before, you've probably read or know or done yourself how important it is to engage even as early as designing research questions and designing the actual study itself. And so if you do have patient partners who are engaged with your study so early, it just makes sense to reflect those partnerships by including patient partners in the grant application. Funders such as CIHR are looking for this now, as well as indications of your collaborations with patient and how well your project is informed by patients who are going to potentially benefit from the research that you're doing. So it's important to be intentional about your patient partner engagement from the start. What that's going to look like, what shape that's going to take, what kind of culture you want to build, because it really sets the tone for your relationship for the rest of the, not only the grant application process, but if you're successful, the whole project. And it's also really important because depending on the length of your relationship with your patient partners, you might be quite early in your relationship. And so thinking a lot about how you respond to invite feedback from, engage with patient partners at this stage is just really going to be very important. And we could go through a whole webinar on that process of engaging patient partners in the co-design of a study. But because we're a little limited on our time today, obviously, we're just going to focus specifically on the grant application part, and specifically CIHR grant applications and the challenges that patient partners might face in completing those requirements, and that you might also face as researchers if that's who you are, and how you might want to think about supporting patient partners. So there are different application requirements for a CIHR grant for patient partners. As Maureen mentioned, they can come in at various levels of engagement on a grant. And there are a number of applications requirements which I've listed here, and I'll go into in more detail when I talk about the challenges involved. But essentially, what is true here is that this can actually be a lot of work. There's a lot of moving pieces in these requirements to apply for the grants. And just remembering, of course, that for most patient partners, or all patient partners, this is not their paid employment. This is something they're doing in their free time, and the hours that are involved in being involved at the early stages of the grant and then adding the requirements of the grant application process can be a lot for people. I wanted to mention that because of the navigation challenges that we've seen in the past, Maureen has actually come up with a really wonderful guide for patient partner co-applicants that really walks them through the process of some of these grant requirements. So It's really wonderful. It gives a lot of definitions in lay language that appear in the CIHR application. She breaks down the application, the deadlines, and then really gets into like how to fill out both the CV and the most significant contributions. And I think that that Maureen is going to put that guide in the chat. Is there now. You're welcome to adapt this and use this yourself. It's a very generic one right now, and it would need to be adapted to your specific grant application and deadlines, as well as any updates that CIHR might have made that for this grants round that we may not have known about. But please feel free to use this guide. So I'm going to talk about 4 main sets of barriers and challenges that we have experienced in our own work with patient partners on research grants that I've listed here. And the first one that I'm going to start with is around the technology and the platform. And I might just start by saying that I am not the most technologically savvy person. So perhaps I'm maybe extra sensitive to these things. But this has been a challenge in 2 real main ways. One I was alluding to before is the number of steps that it takes to be involved in a CIHR grants application. So if you're a patient partner or a family caregiver who's a family partner, taking part in a research grant, you're thinking, okay, well, I'm going to sit down. I know I've got to be on this grant. I know that to be on this grants application, I'll just sit down, take an hour, and get all that done. You actually can't do that. There's all these steps with lag times in between, both from setting up the research grant account, getting your PIN number, getting your PIN, completing these, and then completing the actual application requirements. And then reviewing and consenting. All of those things kind of have lag time built into it. So there's multiple steps there. And they're not necessarily the easiest steps either, because what we found is that the application process is really optimized for desktop users. And that makes a lot of sense if you think about it. It's been designed by somebody at CIHR. And that team, this is their paid employment, and so they're probably working on computers to design the application requirements. As are many of us in the room who are researchers, we're also completing a lot of these requirements on computers. And we found that this is not the case, and perhaps this is even really a growing trend, that many people are actually using tablets and even their phones to complete these requirements. And we all know that websites just often work differently on phones. They look different than they do if you're using a desktop. And so we found that a lot of people had a lot of challenges, and we thought we were being really prepared in a grant that we did recently where we had a meeting with our patient partners and we walked them through the process. And then we scheduled sort of one-on-one meetings with them if they wanted so that we could walk them through it. And we realized during that process that what people were seeing on their phones was just entirely different from what I had seen on my laptop, and made us realize that we really needed to step back and go back and try to actually do the whole process on our phones. And so that we could actually understand what the requirements looked like when we were there. Like certain drop-down menus weren't functioning properly or were in a different, things would look different. And so as a researcher, that's something that you might want to think about doing before you actually sit down with your patient partners to complete their requirements. The other thing was that that because sometimes things weren't working very well, we actually ended up offering to upload documents on people's behalf if they were willing to give us their account information so that they didn't have to fiddle around with the website. And then they would go in and actually just review and consent themselves. And another thing that actually, if I can just go back to the PIN number, another thing that can be really tricky is for some patient partners who have been parts of grants before, they may already have a CIHR PIN. And that's great. But what we actually found was that it might have been some time between now when they're doing this new application for you and the last time they actually used it. And so for some people, or their Research Net account, they weren't actually able to, like, they couldn't remember their password or they couldn't remember their PIN. And then they got locked out of their Research Net account and trying their password. And so for a lot of people, if you're asking them to do things and there's a deadline, a lot of people just come in very close to the deadline and do it. But what we found was um, that people were coming to it last minute and then getting locked out of their account. And then there was that extra lag time. So thinking about building in to your deadlines, things like that, the possibility of technology not working out for people. And then the last thing I'll just say is that you can assume access to Microsoft software. I think for a lot of us working in computer environments, this is readily available for us, whether we work on PCs or Macs. But again, not necessarily for patient partners. And so we ended up PDFing all of our documents so that they would be accessible. So the second set of challenges that people that we found that patient partners really faced was in actually completing the requirements, the contents of the requirements. The applicant profile CV, as it currently stands, has 4 different components. As Maureen mentioned, the CIHR will move to something called a narrative CV at some point. We don't know what that will look like. Or what it will include, but the applicant profile CV includes 4 optional sections and a most significant contributions document, separate document. These pieces are filled out by all, are applicable to all knowledge users, not just patient partners. I think Maureen mentioned that patient partners used to have to fill out the common CV, the CCV. And after some feedback that this was really just not very well targeted to patient partner experiences, the CIHR actually devised this new applicant profile CV and made it usable for any knowledge user. For patient partners, though, some of this can be really intimidating. So I've just pulled out a bit of the instructions from CIHR in completing the applicant profile CV and what people can put on it. And you can see that, like in the instructions for the personal statement portion of it, expertise or lived experience is buried quite deeply, actually, into the instructions. And for a patient partner for whom that's often the most important thing that they're bringing to the table, the most important part of why they've joined your grant application, this might just get missed. And then in the position and honor section, I think that in academia, we're quite used to this language around achievements and honors. They're a big part of academia, but they're not really a huge part of day-to-day, the way that I think people see their own daily experiences or even their work. And so we had a lot of patient partners that we've worked with who just found this section really very intimidating and didn't think that they had anything to write here. And that's really something to think about as well. And it goes back to relationship building. We actually had a participant who, when we met with them because they were finding this process overwhelming, said to us, I just don't have anything to add to this. I don't have anything to put here. But this was somebody who was the parent of a child with a condition. She had been involved in many advocacy and patient groups. She had actually won an honor. She had actually been recognized for her volunteer work. These were all things that that would have fit, but she just didn't connect it to what she was reading in this statement. And so we wouldn't necessarily have known that if we hadn't had the time to build that relationship with her prior to actually filling out the grants application. And so that piece of relationship building is really important because you then, as a researcher, will then know the things that your patient partners are bringing to the table and be able to maybe help guide them through highlighting some of those things if they wish on this application process. Just another example here in a different section on the applicant profile CV. Again, knowledge creation, knowledge sharing, knowledge translation. all things that maybe you're perhaps more familiar with in an academic setting, but words which are perhaps not, people are not very familiar or comfortable with, and just might require some additional work with you, as Maureen says in the guide, to just really break down what these things mean and what kind of experiences might fit in them. And also that these things are optional and that people don't need to actually address all of the sections in the applicant profile CV. Another thing, you don't need to read what's on this slide here. I've just sort of highlighted this to demonstrate that there's a lot of overlap between the CV, the applicant profile CV, and the most significant contributions document. So this process was designed for researchers and clinicians in mind. And so it makes a lot of sense to do something like this, because for a lot of people, your CV is going to include dozens, if not hundreds of things, right? Published papers, research grants, education, committees, like all sorts of things. And so it then makes sense to say, well, if you've got like 75 things on your CV that are relevant, we want you to highlight in this contribution statement the 5 things that are going to really, that you really feel are most important to contributing to this project. But if you're a patient partner, that looks really different. Your reason for being on this grant is maybe solely, but certainly most importantly, the lived experience that you bring as a patient or a family member of a patient to this research project. And perhaps you have other work that you've been involved in that you want to describe as well. But for a lot of patient partners, that number of things that they will be highlighting may be much smaller than what a researcher, the number that a researcher would have. And so what ends up happening is that the CV and the most significant contributions document just end up feeling very repetitive. They feel like they've just created this document that they have maybe felt a little overwhelmed in creating this CV. They feel relieved, and then they move to the most significant contributions document. And a lot of them feel like they're being asked to say the exact same things. And so this is just something really that you should be aware of as a researcher and really be prepared to support people through, reassuring them that they don't need to write a lot of information, understanding and acknowledging that this can be very repetitive, providing that one-on-one support. And even if they're overwhelmed, in some cases, what we did when participants were feeling overwhelmed, we sat down with them and asked them to tell us what information they wanted to highlight, or to email us and sort of write that in bullet points. And then we drafted a brief statement and sent it back to them so that they could edit it or change it or whatever. I think for a lot of people, just the act of creating a document from scratch when they don't have a blueprint for it can be really difficult. And so if you can think of creative ways in which you might be able to help them jumpstart that process, that can be a real help to partners on your project, and sort of just take out some of that mental and time work. The time commitment and support issue is related a lot to the content issues that that we described, and the technology issues that we described. But one of the things to think about here is, if you know this, and it's really important for you to be quite familiar with the process of applying for a grant application from the patient partner perspective, what that's going to look like for them. Then thinking about ways to support them through that process and ways to acknowledge the time commitment that they're giving is really important. And this is a real challenge here. And I'm not sure I have a lot of answers here, but I just wanted to bring this up and discuss it. Which is that for most times, patient partner honoraria come out of grants. And so what do you do at this stage where you haven't gotten a grant yet, and you're trying to acknowledge and compensate patient partners for their time? So what we did was, we were lucky enough that the nominated principal applicants on our last grant had a fund available to her as faculty. That might be something for those of you who are planning on being nominated principal applicants yourself, or who work for NPAs, that they might have a fund that they might be able to draw from to provide a modest honorarium. And then again, you want to think about the size of that honorarium. And again, that's going to be a balance between what you're able to share given the funds available to you, and also taking into account a really in-depth understanding of the time commitment that patient partners are going to put in. So you want to think about, well, what am I asking them to do? How much time are they committing to being involved in meetings, not only taking part in meetings, but the preparation for meetings, arranging childcare, reviewing documents, how much time are they spending emailing and providing feedback, and then to really think about how much time is involved in the actual process of applying for the grant. For researchers, clinicians, this is our paid employment. For patient partners, it's not. And so that acknowledgement of how much time they're actually spending of their own free time can be really important. And they might need support for other participation costs, such as transportation and childcare, depending on what you're asking in order to be on the grant application team. I want to spend a little bit of time talking about additional barriers for groups who are systemically underrepresented in research. Examples are groups who are racialized communities, gender, people who identify as women often are underrepresented in certain types of research. And we know that there have been more long-standing, or there have been examples in the past and currently, where groups who might benefit most from the kind of research, the interventions and outcomes from research, are not actually included either as participants or as patient partners in that research design. And so if this is something that you're thinking about, again, I don't necessarily, we're not really focusing today on the whole process of engaging patient partners from the very beginning of the process. But I just want to mention a couple of things here, and just sort of thinking about the additional time that you might need to do some additional outreach and relationship building. You may, depending on your connections to the communities or groups that you would like to have as part of your team, you might just need some more of that time. It's also really important that researchers be familiar somewhat with issues of equality and social justice, and the barriers that the members of the groups that you're engaging are actually facing when it comes to health research and when it comes to health services as well. Often we see underrepresentation in both. Because of that underrepresentation, and because underrepresentation often means discrimination, having a good understanding of that discrimination and the community trauma that can result is going to be really important for your own ability to be sensitive to and responsive to the issues and the barriers that people might face as a result of their membership in groups underrepresented systemically in research. One of the things to think about is avoiding making somebody the token minority. And that is, if you think about, for example, being at a table with 20 people and everyone at the table is white, and you've invited one person who is not white to the table. That person then is sort of left on an island, especially if there are decisions being made or discussions in which some measure of inequality or trauma or injustice is being raised. And that leaves that person alone on an island to be the only person perhaps who is going to maybe see and raise the issue. And so thinking about whether you can bring in multiple people who might be underrepresented so that there isn't this feeling of being alone and this feeling that if they speak up, they've, that there might be repercussions for them. That often that comes with other work too, but just that sort of knowledge and comfort of having more than one person at the table who doesn't look like the majority, or it doesn't come from a group that is the majority group. The other thing to think about is academic speak and how we talk about things in the grant application. And I've been alluding to this throughout the process, the idea of the knowledge translation, knowledge sharing, and some of the other language. But just for fun, I pulled out some of the instructions for creating your most significant contributions document, and I ran it through the FleshCancade tool to find out what the grade level was. And you can see here that the grade level is basically university level. And when I complete an ethics board application and a consent form, my ethics board says we recommend that you have a grade level, a grade 8 reading level for your consent forms. The idea being that you really want lay people to be able to understand the document that you're putting in front of them. And I think that this is really true too when you're thinking about working with patient partners, especially patient partners who may be newer to research itself. It's really important to take a step back and think about the words that are in front of you, that the words that are being presented to a patient partner and how they're going to interpret this and whether or not they're even going to know what this means. Like, you might know what this means, but is there an easier word, or is there an explanation that you can give that would make that a little bit easier to understand? We're hoping that some of this will be different when CIHR comes out with their new narrative CD, but we don't actually know yet. So I just want to finish by reviewing some of the tips for supporting patient partners. I've talked about a lot of them already, but supporting patient partners to this process, I think that the key one really is to build trust. I think that a lot of the tips that will follow, a lot of the barriers and the challenges that people might face in joining your grants and being part of the grant application will be helped enormously if people feel like they can come to you and say, I don't know how to do this. I'm finding this really frustrating. I need help with this. To be able to build that trust. And that takes time. And that goes back to what I was saying at the beginning of my slides, was to really start early, because you're going to need to build in some of that time to get to this point. And to be really prepared to support them through all grant application requirements. I know that as somebody who as is research staff, especially the closer you get to the submission of the grants application, the more you're juggling, the more you're trying to do, the more rushed you feel. And it's really important to be able to carve out this time that people need in order to sit down for one-on-one meetings, phone calls, emails, reach out, like proactive reach out on the part of the researcher, and to really be able to provide them with the support that they need and may not feel that they can ask you for. Even if you've built all that trust, being able to proactively reach out and provide that support is going to be really important. Trying to complete requirements, like I was saying, on a phone or a tablet. And maybe also thinking about assigning a contact person from your team, especially if you are a researcher and the nominated principal applicant, and you're getting close to that deadline time. You know that you're going to be working, I don't know, 16 hours a day trying to complete your grants application. And so assigning somebody on your team to work closely with people whom they can reach out to and get a response pretty quickly can be a really nice thing to do. And I'll end there. and thank our collaborators on some of the things that we learned and put together for this presentation. And I will then, I think, turn it over to you to ask questions, and I'll stop sharing my screen now.
Okay, thank you
Wonderful
so much.
presentation.
Sorry. I was going to moderate the question period. Is that okay?
Yeah, by all means. Yeah, if you'd like to do that, Maureen. Maybe we'll get started with Deb in the Q&A was the first question that came in.
Okay, because I don't see the Q&A.
Okay,
I just see the chat. So
let
I'll
me
you
read
do
it
that
out
part.
then. Okay,
Right.
okay, that sounds great. But thank you both for an excellent presentation. You really did cover so many important details on how we can support patient partners through this process. So here's the first question. Do you suggest that patient partners, when joining a team from the start, take the initiative to state what their involvement should be in terms of designing the question, designing and writing grant applications, etc.?
I can take a stab at answering that first, Sita. So years ago, when I started in this world, the guidance to researchers was always tell them exactly what you want from them, be very clear about your expectations, write it all down. That's changed. So it should be a discussion. It should be a negotiation. You should be asking your patient partner, what are you comfortable in doing? What would you like to do? Which parts would you want to be involved in? No one you can give you can be a great contributor, an equal partner without doing every single thing. I know for myself, I'm not a big person in the data analysis part. If they're doing a literature review, kind of want to know what's going on in the background, but I don't really want to be pulling abstracts and read that kind of stuff. And the researcher also has to consider what is their budget for doing that. So if they're offering that kind of involvement, do they have the budget to support that if that person wants to learn how to do that and do it? So there's a lot of considerations there, and that's why I suggest it really is a discussion, a kind of negotiation, get to know your partners, get to know what interests them, and let them get to know the research team. And the research team always has to consider that there'll be compensation for the work that's done as the patient partners. So, and also their own capacity. Do they have the capacity within their team to actually do some of the training that people might want to do? There could be people who are already trained. That's different. They're only going to find that out if you ask people that. So that's how I see it, and that's changed because when I started, it was very clear. You just lay everything out and then have them agree to that, and it's great to see the evolution of that. That really is a discussion now. If you want to add to that, Andrea, but
I think you said it perfectly, Maureen.
Great, thank you. Great answer, Maureen. So here's a question from Stuart. Would you have any suggestions for the requirement to provide an institution, so category of institution for co-applicants? Would you just write patient partner, or would you have another advice?
Yeah, you don't have to put a patient partner, doesn't have to put an institutional affiliation. I like to put patient partner because I want to be clearly defined as that. And even though I do have an affiliation now with the University of Toronto, I don't put that unless it's I'm specifically going in with that affiliation. So they don't have to do that, which is good. And people have different ways of how they like to identify themselves. Some want to use patient partners. Some want, you have to kind of decide with them too what they're comfortable in calling themselves. I had one more thing that I thought about when I wanted to add to that first question about when you're talking to people, negotiating with them. The advice that I tend to like is that you're coming in as a patient partner with lived experience. That's why you're coming in, but you're a multifaceted person, and maybe in your other life, you're a designer, or you're a translator. And so when you have these discussions with your patient partners, you may discover that, well, they have other things that they may bring to your team also. That's never it should never be mandatory, because then that makes people who don't maybe have those other skills feel like they need more than lived experience. You never need more than lived experience, but if you have other skills and you want to apply them, you should let the team know that. And the team should be asking, the team should be open to hearing those kind of things. I mean, some patient partners are statisticians, so when you have those discussions about their roles and that, those kind of things come out, and sometimes you might be really surprised that some people are marketing experts. Like it just depends what they bring, and when you don't have those conversations, you don't find out any of that. So
yeah, so you're speaking to seeing the person as a whole and everything that they're bringing. Yeah, wonderful.
Yeah.
So here's the third question in the Q&A, and then you can flip over to the chat if that's easier for you to moderate, Maureen. So the question is, would it be useful for patient partners to just repeat the most significant contributions portion of their CVs as the most significant contributions document?
I'm going to give you my opinion on that, because I'm very frustrated by the process, and I copy and paste. I'm like, the heck with this. Like, they're asking me to repeat the same information. That's not my problem. Have they not noticed that? I just copy and I drop it in. I paste it in. I'm not going to be bothered rewording basically the same question. And I'm hoping that's going to change in the new guidance. But yeah, but I mean, other people may not think, they may think that if they do that, they're doing something wrong. So far, no one's have to come back to me and said, "Oh, you already said that." And I probably filled out, I'm not going to say hundreds, but many grant applications. And that's what I do, because I'm frustrated with the process, and I'm not going to spend an extra minute on answering a same question with different wording to make it look like I've changed it. So that's my kind of advice on that. I don't know, Andrea, do you want to add to that?
I agree. I think that it's really not, I don't think that reviewers are going to be penalizing teams because a patient partner's most significant contribution and applicant profile CV are the same. And if Maureen is any indication, they do not. So, given the number of successful grants that she's been a part of. This is actually not something that somebody's asked, but I think I should just mention it because I think it's important, and I forgot to. And that is that as researchers, we also need to be aware of privacy, because what's being shared by patient partners in their applicant profile CV and most significant contributions often relates to lived experience. It's really important to know how CIHR is going to use that information and who's going to see it, and to convey that back to your patient partners before they begin the process. Prior to, I think, was it last year, Maureen, they didn't say, CIHR didn't say what they did with that information. They've since added information to their instructions that says a little bit more, but again, you can't be assured that people are going to read that, and that needs to be on you as a research team to share that with your individual patient partners.
Yeah, for people who didn't miss it on the chat, that was my motivation in getting that first guide out there, was that people were sending me their things to help them, to edit them. And I was, oh my goodness, like, do they have any idea that means there's 67 applicants on that grant? They can all see it, plus whatever CIHR staff is involved, plus the reviewers. And I see Sandra Holdwert's on the call. And last year, her group, oh God, I'm going to say PAN, Patient Advisory something, invited Andrea and I to present on this topic for patient partners. And there were people on that call who said, what? What do you mean everybody can see what I wrote? Can I pull that back? And I complained about it on Twitter several times and said, warning, warning. So they did go in and make the change, but didn't tell anybody that they did. So I was still giving out the old form. And Andrea is the one who went in and did some digging and said, oh, look, Maureen, they have added a statement. Thank you, Sandra. Patient Advisory Network, they have added the statement. They didn't tell anybody they added it. So anybody who was using the old form was still there. And the questions are very personal if you're doing lived experience. So you have to really think about that. How many people can see it, and how much information are you comfortable in sharing? And I think the statement they put in was basically, don't share personal information, but they don't explain why. We want to know why. Like we be transparent and say, because this, these are the people who could potentially read it. So I think that was something, that's really what motivated me to actually do it, was I was really concerned about people sharing their personal information without knowing that it was going to be seen. So there was a quick question there about how many patient partners. So you never want to have the only lonely patient partner. That's a big no-no. If you're working very closely and you've got a small team, 3 is a nice number, 2 is a good number too. And as Andrea said, consider if you're working with people from underrepresented groups, that you're not just working with that one person. And it doesn't mean that because you have 2 or 3 patient partners, that's all you have on your study. But those are the ones that you're working with as equal patients. And then for that, you can fan out and have advisory groups and other people who will work with you. But only lonely is definitely not something that we encourage. So.
Thanks, Maureen. So we do have one more question in the Q&A box, but if there were any burning issues that you wanted to address from the chat, please go ahead and do that.
Go ahead, Apsita.
Okay. Do you have any recommendations or managing expectations of patient partners regarding discrepancies between what the engagement plan is drafted in the grant versus what materializes during the project according to changing capacity and resourcing? Do you recommend keeping engagement plans in grants broad to mitigate risk of overpromising?
That's a really good question. I've had that happen to myself where I had to go back and say, I thought you said you were going to do this. I don't see that happening now. Oh, it changed. So I would say to try to keep it as broad as you can and to be transparent. If you are making a change, why are you making that change? How is it going to affect your engagement? I think a lot of it is transparency. I think patient partners, understand that things happened. And maybe that you didn't get, maybe you were trying to get a $300,000 grant and you got a $200,000 grant and you had to make changes. It's really about the transparency and communicating that. So
that's great. Thank you. So that's it for the Q&A box. Did you see anything in the chat that you wanted to address?
Yeah, Carol had a question about co-authorship. There's a great Equator video. If you go on the Equator website, we can try to send an Equator video on exactly that question and with all kinds of guidance about patient partners and authorship. And I think you would enjoy seeing that. And what we say to our patient partners is you have to meet those ICJMC international standards, and we will help you meet them. And this is what the standards mean. There's also a really good article from Dawn Richards about those standards too. And she has a box where she shows the standard and how that would apply to patient partners. So there has been some work done in that because it is common now. So, right.
Andrea, any final comments for you before we wrap up?
I think that's great. Thank you.
Okay, wonderful. Well, we thank you both for taking the time to do this excellent webinar. I think there are lots of really concrete questions that you answered along the way throughout the presentation, and I hope this helps research teams feel more confident in this component of their protocols, their proposals that they're putting together, and supporting patient partners with being more included in the entire process. So thank you so much for taking the time, and thank you all for joining us today. Please stay tuned to our website and the ACT Education newsletter, where we'll be telling you about all of our upcoming events for this year. It's a busy year. We've got a lot of great initiatives to tell you about. So please stay tuned and join us for upcoming webinars. So enjoy the rest of your day, and we'll see you next time. Thank you.
Thanks, everyone.